Today we're going to talk about risk mitigation of infection and breast reconstruction surgery. And this is a big problem, as we heard in earlier sessions today. And we have 4 panelists today that will talk to us. But before I introduce the panelists, we're supposed to have some questions here, and we're just going to poll the audience. Let's restrict this question to people that do implant-based reconstruction. What type of dressing do you use? And I'll just run through these and just raise your hand if you use these. Tegaderm, Steri-Strips, Aqua AG dressing, Mepilex border, Acticoat. Okay, so a lot of Steri-Strips. Anybody use negative pressure wound therapy, incisional or VAC? Couple. And how long do you leave your dressings on? So no matter what you answer, just how long do you leave a dressing on? 1 to 3 days, 3 to 7 days, over 7 days. So a real variety. How many of you use nitropaste? A few. And what has who believes direct implant versus tissue expander? Let me know what you think has a higher infection rate, direct to implant or tissue expander. A lot of no votes on that one. So when you get an infection after you put in, this is for tissue expanders or implants, where do you think the bacteria originated from? And there are 3 choices: skin flora, breast ducts, or contamination in the OR. So how many think skin flora, breast ducts, and OR contamination? All right. So I think the point of these questions is that we have a whole lot that we have antibiotics, another great area of diversity. For implant-based reconstruction, the choices are none, 1 pre-op dose, less than 24 hours, or until drain is removed. How many for none? 1 pre-op dose, less than 24 hours, and until the drains are removed. A whole bunch. So I think that these questions show that even for very simple things that we do, we don't have great answers in the literature. And we may not fully answer these, but I think hopefully some of the people in the audience will take on some of these questions, because I think this is a very important topic for us. We're going to first hear from Michael Newman from Torrance Memorial Hospital. I'll follow him. Then we're going to hear from Mark Villa, and then Mo Nahabedian will be the final speaker. Thanks.
So for those of you that don't know me, my name is Michael Newman. I'm a plastic surgeon in private practice in Los Angeles and a plastic surgery group. And I also have a clinical faculty title at UCLA. And I'm going to be talking about risk factors for surgical site infections with you this morning as part of the beginning of this panel. So trying to move forward 1 slide. Try the mouse. There we go. So we brought up some kind of controversial questions there in the beginning, which I think hopefully we'll maybe discuss a little more at the end, because I think they are controversial. But maybe we'll start with some simple concepts and some stuff that we can all agree upon. You know, one, we are plastic surgeons, and I think all of us, by being here today, we like what we do. But I think we can also agree that we don't like having complications. You know, they're stressful, they're distracting, they're emotionally draining for us. They take time away from us in our practice. They're difficult for patients, and they're a big financial cost to healthcare. So we would love to have fewer complications. And really that's the point of this panel today, is to try and find ways to decrease complications in our practice, specifically the complication of infection. And I think infection is a complication that we see frequently as plastic surgeons. And the infection complication specifically has very high risk consequences for our patients. Similar to the orthopedic surgeons, when we have a complication of infection, typically there's an implant nearby. And so that implant can get infected, meaning sometimes that implant has to be removed, which can have very life-altering effects on a patient and then create a lot of difficult stress for us and a lot of healthcare dollars being spent on trying to get that patient back to where they started. So what I'll talk about today are just a couple of cases so we can relate to what's going on and then go through some data. And the data is really specifically going to be about immediate breast reconstruction and the incidence of infection as well as the risk factors for infection so that we can figure out ways to select patients better, decrease the risk of infection, and even manage some of those infections better. So this is the first case. This is a 44-year-old female with right breast cancer. She had bilateral mastectomies and expanders placed, and this is a picture of her 5 weeks after surgery. She recovered well during the first few weeks of surgery without a problem, and then called me saying, you know, doctor, my breast looks a little red, what should I do? Now, as many of you can probably relate, that phone call usually comes in on a Friday at around 4:30 p.m., typically on a weekend when you're trying to leave town to come to a meeting or something like this. And my first instinct usually is to say, why didn't you call us earlier? Could you have called us this morning so we could set you up with infectious disease and manage this faster? But no, it seems like they always come in on Friday afternoon. And so I did tell this patient, look, come in, we'll take care of it, we'll get you into the hospital or the ER and make sure that we can address your problem. So fortunately, she had a very good outcome, which isn't the way it always goes, but she got her IV antibiotics. She resolved her erythema on her right breast there, as you can see, just a few days later. And then she proceeded to have her reconstruction with expanders replaced with implants and fat grafting, and she did well. But as we all know, that's not the way it always goes. So as a contrast, I'll show you another patient, kind of a similar starting point. She had bilateral mastectomies for right breast DCIS. She had expander reconstruction. And soon after, this is a picture 1 week after surgery, she developed a little bit of necrosis and some erythema of the lower pole of her right breast. So same situation, we got her into the hospital, gave her IV antibiotics, her erythema got better, but she ended up developing a little bit of dehiscence along her incision, had some debridements, and then eventually ended up in a very different and bad place with loss of her reconstruction. So quite a devastating complication and something that we'd like to avoid or at least reduce as much as we can for all of us to have less stress and to have better outcomes. So how often does this happen? How often are people getting infected after this type of surgery? There's some old literature that talks about rates ranging from 1% to 35%. So that seems like a massive range. And I'm confident if we polled the audience that nobody out here is having a 35% infection rate after their breast reconstruction surgery. Otherwise, they'd probably be kicked out of town. But I'm also pretty confident that nobody's having a 1% infection rate, or maybe they're saying that, but they're maybe not being entirely truthful. So if you look at some of the more current literature, I'll talk about 3 studies today briefly. These studies show rates ranging from 3.5% to 10%. Now that's still a pretty big range, but certainly more narrow than the 1 to 35% number. And the real question that we want to try and answer is, what is that percentage? You know, when we counsel patients, what can we tell them is a realistic number of their risk of having an infection complication from their immediate breast reconstruction? And then also, what are the risk factors? Which patients are going to be more likely to have an infection? Are there some patients that maybe we should say no to about immediate reconstruction? So the first study is a prospective database, National Surgical Quality Improvement Program, which is a prospective database from the American College of Surgeons. And so a group from USC pulled data from almost 50,000 mastectomies, a massive number. And this data set is very rich, so it includes a lot of details regarding the patient and their risk factors and criteria. Almost 20% of those patients, almost 10,000 of those patients had reconstruction. And the follow-up was only 30 days. So the shortfall of this data set is it only looks at complications that happen within 30 days after surgery. They found that the incidence of infection in patients with reconstruction was 3.5%. So a pretty low number, and that would be a great number if it was really true. But don't forget, it's only a 30-day follow-up. So when they break down the different qualities as to what factors increased the risk of infection in those patients, there were a few very specific and helpful criteria there. One is if that patient had reconstruction, they were more likely to get an infection. So if they just had a mastectomy by itself, the infection risk was lower. But if they had reconstruction, the infection risk was higher. And they looked at weight, and they broke the weight categories down into overweight, obese, morbidly obese. The increased risk of infection went up for each one of those categories. So obesity definitely has a very high risk for infection in these patients. The other criteria that they noticed that were significant for increasing infection risk: ASA score over 2, operating room time that was prolonged, heavy alcohol use, and a history of flap failure. For various reasons, if there's a flap failure, you're going back, repeated surgeries, you can see how that would increase the infection risk as well. Now, they did look at these other criteria, and what they noticed is these did not show a statistically significant increased risk of infection. And this was really a surprise for me, because I think a lot of these, intuitively, we know as plastic surgeons, do seem to increase risk of problems with healing, but it did not lead to an increased infection risk. And those qualities were tobacco use, diabetes, chemotherapy, radiation, and blood transfusion. And so one of the things we can wonder is, did some of these factors not come into play because the follow-up time was too short, or do these factors really not contribute to the risk of infection? Well, let's look at some of these other studies. The next study I'd like to talk about is an insurance study. So this is from a commercial insurance company where almost 20,000 mastectomies of data were pulled. The majority of these patients had reconstruction, and the follow-up was 6 months. So this is a much longer follow-up than that 30-day study. And they found a 10% risk of infection in patients that had reconstruction. And once again, patients that did not have reconstruction actually had a lower incidence of infection. So you can see that number, 10%, is almost double that 3.5% from that previous study, showing that a lot of these infectious complications are happening after that 30-day time period. And they were not able to look at all the data points and all the variables that the NISQIP study looked at, but they did see that there was an increased risk for infection in patients that had bilateral surgery or patients that had any type of reconstruction, as we mentioned. There was also one diagram that I thought was very helpful, showing the frequency of infection in relation to time. And so really what I want us to focus on are these black bars, which show patients that had mastectomies with immediate reconstruction. And then on the bottom here is a timeline with days. And so you can see there's a peak of infection in patients around days 15 to 25. But you can see here's the cutoff for 30. If we looked at only 30 days, we would catch that peak, but we would miss out on catching all these other patients that are developing infections later. Even all the way out to 180 days, we're still seeing patients that come in with an infection. So I think this shows us the importance that we need to follow those patients for a long period of time. A 30-day study is not enough to capture all the infections that are coming up. Another side note about this study that concerned me a little bit too is that it's amazing what the insurance companies are really collecting. They're collecting data on all of us. So sometimes we think we're just doing what we need to taking care of our patients, but really Big Brother's watching us. There's a lot of data out there that the insurance companies are collecting on us, and we don't even know it. So for the final study, this was a longer study, so a 1-year follow-up, a prospective database with multiple locations following 1,600 patients, all of which had reconstruction with an implant. Those other 2 studies had reconstruction with implants or with flaps. This study was all implant or expander-based reconstruction. And they found the surgical site infection was 8%. Kind of similar to that other study we looked at right before. And similarly as well, they found that half of all the infections occurred more than 30 days after surgery. Once again, reinforcing that we need to follow these patients for 6 months to a year to really capture all those infections. And they found that obesity and radiation after placement of a tissue expander were really the only criteria that increased the risk for infection statistically significant. These other criteria, which were looked at as part of the study, and once again, these patients are followed out for a year, so this is a pretty long term. They found that chemotherapy, diabetes, tobacco use, use of acellular dermis, none of those increased the risk of infection in a statistically significant way in that study. So in conclusion, to summarize some of that data, surgical infections in patients having immediate breast reconstruction are fairly common, and the number that we can now confidently quote to patients based on that data is around 8 to 10%. And there are certain risk factors that we know will increase that patient's risk for infection, and we can counsel patients now and say, these criteria that you have are going to increase your risk just for awareness, and maybe some of these patients we should be saying, you're at too high of a risk. Maybe you should not be having reconstruction immediately, maybe have it in a delayed fashion. But these factors, radiation, obesity, ASA score over 2, prolonged operative time, heavy alcohol use, flap failure, and bilateral surgery all increase the risk of infection. And so what I'll do next is I'll hand this over to Dr. Orgel, who will go into detail about one of these qualifications here, in particular obesity, and talk more about how that risk factor really increases infection risk for our patients.
Thanks very much. I'm going to talk to you today about a big problem, obesity. And if we look at what we're doing in breast reconstruction today, there's a tension that we all face because we see an aging population, we see more early diagnosis, we have this Women's and Healthcare Cancer Rights Act that allows everybody to get it. So those all go on the demand side. And then our complications, as we just saw, obesity, aging, diabetes, radiation therapy, and now we have to deal with ALCL is an issue, all relate to complications. And then at the same time, we're in an environment where they're decreasing dollars for what we do, and those are primarily related to the fact that our employers no longer want to pay double-digit increases for insurance premiums. A lot of that's driven by high-cost pharmaceuticals, government deficits, and then we also have competition from non-plastic surgeons. So all those factors go to decreased reimbursement. And so really, the only way out of that is going to be to provide more efficient, higher quality care over the future, no matter how the politics ends up. So we want to find out ways that we can lower the risk of complications, make our operations more efficient, which is going to come through standardization. And based on those questions that we went over at the beginning, we can see we are a long ways from standardization because we don't have agreement on even really pretty basic things. We need better data and we need more cost accountability. So I'm going to talk about obesity, and if you look at self-reported obesity in the U.S., I mean this is a big problem, and you can see geographically it depends on where you live. We're in Massachusetts. which is reasonably good, but in the South, it really gets pretty difficult. Then if you look across the country, it varies by age, but when people get breast cancer, if you look at the women, 42% are obese. And the health effects of obesity are tremendous. Type 2 diabetes goes up, hypertension, heart disease, stroke. The risk of cancer, as we'll talk about, is basically twice as high for breast cancer in obese patients. Sleep apnea, osteoarthritis, and kidney disease. And, this is a really recent phenomena. If you look at this is BMI over 30 from the CDC, from 1914 to 2014, you can see how this has changed dramatically across the country. And then if you look at diabetes, you'll see a similar map. And so the thought is that obesity is driving a lot of the diabetes. So it's thought that obesity accounts for almost 3/4 of the risk for hypertension, and that 3/4 of the risk for end-stage renal disease, and that the risk of all sorts of other diseases go up the heavier you get. So this is hypertension rate by states, looks very similar to some of the other maps we've shown, and the thought is that with obesity that you get some loss of nephron function, and that you have to dramatically reduce your salt intake. Stroke, same thing. And sleep apnea, there's a huge problem with sleep apnea with obesity and all these pathways that go on that relate to it. And osteoarthritis, again, huge increases in the need for things like total knee replacement if you look at osteoarthritis. So the question is, as we as doctors, these are the patients we're seeing for breast reconstruction because they have a higher incidence of getting breast cancer because they're obese, and they have a higher incidence of complications for what we do because they're obese. And the question is, what, are we just pure technicians, or are we physicians that want to manage this, and how do we best manage that? And these are all questions we don't know the answers to, or at least I don't. So we looked at the literature, what's out there today, which is not terrific, because it turns out when we looked at this, there are actually no prospective randomized trials to look at. These are all retrospective series. And so this, we looked at PubMed, Embrace, and this, by the way, this is by Andriana Pania, who's a student at University of Cambridge in the UK, Ria Agaz, who's a plastic surgery resident and a PhD student at Oxford, and Brady Sieber, who's one of our residents. They did all the work. But they looked at these papers, and they excluded a bunch, and they ended up with 33 that they felt were reasonable to look at. And these are the inclusion and exclusion criteria, but we basically wanted studies that carefully documented the outcomes. And so these are the studies. They're a little hard to read. Many of you in the audience have written some of these studies. And then this is a standardized risk calculation. So for each study, the size of the blue box is related to the size of the patient population, and then the arrows show the confidence intervals, and then down at the bottom shows what the aggregate is. And so in this case, surgical complications in obese versus non-obese women for breast reconstruction, the relative risk is 2.29, so twice the risk. And then if you look at medical complications, again, down at the bottom, this is going to be 2.80, so almost 3 times the risk for medical complications. And then, so what did they get? And it's just the things that we've all seen, fat necrosis, hematoma, hernia, partial flap failure, and And wound dehiscence and wound infections, you can see, were the two that were the most highly significant. And that's what I think most of our panelists will talk about. And so then you can break it down into autologous reconstruction, 2.59 relative risk, or you can look at implant-based reconstruction, 2.64 times relative risk. And then, then if you look at breast cancer risk, which is why do they get breast cancer in the first place, but also many people will have a contralateral breast, and so they're at risk to get breast cancer in the future. The American Cancer Society thinks that there's a 1.5 times risk in overweight women and 2 times in obese women, although this is a little controversial because some people think that in premenopausal women, actually obesity is a bit protective. And so these are data curves. This is an old study back showing premenopausal, which is actually protective and postmenopausal based on BMI. But overall, most people, if you go with what the American Cancer Society says, it's about 2 times for being. And here's another study which shows the increased risk based on adult weight gain. So then if you say, well, how are we going to prevent breast cancer? Well, there's a whole bunch of things you can do in both premenopausal and postmenopausal women, but the ones that are highlighted here are maintaining a healthy weight and physical activity for both of these. So these are things that probably, just as being good physicians as we interact with these people, a large number of which are overweight, we're going to have to deal with. And then I think the other point to make is that if we look at the 8 to 10% complication Dr. Newman just told us about, most of those complications are going to be in obese patients. And so if we can figure out a way to treat them and minimize their complications, that will actually have a positive effect on all our other patients. So obesity is associated with this meta-inflammation, and this may be part of what drives everything. These studies are all consistent in that there's an increased occurrence of infection and necrosis in our obese patients. And because breast cancer is more common in obese patients, we see a higher proportion of those in our practices. And so we need to better inform our patients and be better educated about obesity. We need better outcomes data, and that hopefully we will be able to figure out strategies to reduce our complications in our obese patients, and that will help all of our patients. Thank you. All right, Mark.
Good afternoon. I'm Mark Villa from MD Anderson Cancer Center here in Houston, Texas. And I'm going to talk to you a little bit about a system we put in place at Anderson just for the salvage of infected tissue expanders. And so I'm here on a Convitec-sponsored panel. I'm not sure what that makes me exactly. But looking at breast reconstruction in 2013, 90,000 patients underwent the procedure. 70,000 of those were TE implant reconstructions versus 20,000 autologous. And so, we all know the benefits of a TE implant reconstruction, or the purported benefits at least. Complication rates can be as high as 53%, as reported in this paper by Bennett et al., most commonly being infection exposure and unplanned return to the operating room, all of which increase costs for patients having these complications. The infection rate in implant-based breast reconstruction in this paper is anywhere between 1% and 35%, depending on what you look for. These are some of the risk factors purported to increase risk of infection with tissue expander-based breast reconstruction. And as we all know, these problems, they can be complex and severe. The treatment can require long-term antibiotics, inpatient hospitalization, and return to operating room for explantation, with the effects of increased cost and delay of adjuvant therapies, including chemotherapy and/or radiation. And so traditionally, the management has been explantation with or without reconstruction, or delayed reconstruction, explantation with or without autologous reconstruction, or salvage. And we're going to talk a little bit about salvage and what we've done at Anderson to try and improve our rate. So looking at our data in-house for the 10-year period between 2003 and 2013, we had an infection rate of 12%. And of those that ended up with an infection, 50% of those tissue expanders were explanted. And so when we looked at the responsible organisms, we found that the most of them were methicillin-resistant staph, or MRSA. Then another 20% were methicillin-sensitive staph, 7% were other gram-positive cocci, and the next largest was 14% were Pseudomonas species. And so what we wanted to do was create a standardized, same-day, multidisciplinary protocol for managing patients that were suspected to have infected tissue expanders in an attempt to improve our salvage rates while avoiding inpatient treatment or returning to the operating room. And the services involved in this were plastic surgery, infectious disease, and diagnostic radiology. And I would love to take credit for this whole thing, but it was really spearheaded by my colleagues George Viola in infectious disease and Don Bowman in plastic surgery. And so these were any patients who underwent mastectomy and TE placement were included in this cohort, and they presented with early signs of post-surgical site infection. So basically any red breast that presented, we would send them over. Patients on that day when they presented received an ultrasound to assess their fluid collection, aspiration, and culture of any periprosthetic fluid if it was in fact discovered, and an infectious disease consultation for the commencement of empiric antibiotic therapy. And the empiric therapies generally targeted staphylococcal and pseudomonal species just because those were what we found, as I noted previously, were the most common organisms found in these patients. This is our algorithm. It's a little bit hard to follow, but it starts with whether the patient was hemodynamically stable. And if they were hemodynamically stable, they went into the outpatient arm of this. If they were not, then they came inpatient, received IV antibiotics, and likely explantation. And so the infectious disease clinic is here. They look for periprosthetic fluid. If there was not periprosthetic fluid, then they were started on empiric antibiotics. If their periprosthetic fluid was present, it was cultured. If the cultures are positive, then they basically either continued empiric antimicrobials, or if the cultures revealed anything, they went on to a more specific regimen. And so ultimately, if patients responded to the empiric therapy, they were continued on that for 2 weeks. If it was finished at that point, then there was no more treatment rendered. And if the redness or symptomatology continued, then they were given additional antibiotics. These were the drugs that were used empirically, and they were, again, targeting staphylococcal and pseudomonal species, and they were designed for the penetration of biofilm. So the oral regimen was minocycline and/or linezolid and ciprofloxacin, as well as, the outpatient was minocycline, ciprofloxacin, and rifampin orally, or if it was an intravenous, it was minocycline or daptomycin, meropenem, cefepime, or rifampin. And the patients were kept on those for 2 weeks, and from the period of, it was February 2013 to April 2014, we had 26 patients who went over and went through this algorithm. Of those 26, 19 had their tissue expander salvaged and 7 had explantation. I'm looking at some of the clinical and surgical characteristics of this. There was a slight association with the presence of ADM in those who had their TEs explanted, but it didn't reach statistical significance. Looking at some of the infection characteristics, there should be a box here up at the top also, but it seems that if you look at the median time for the onset of infection in those that were able to be salvaged, it was 42 versus 20, so it's a little bit later in the patients who were able to be salvaged. Presence of a drainage catheter at the time of infection was statistically significantly associated with explantation of the tissue expander. A presence of any systemic symptoms, and in this case it was a temperature greater than 99.8, was associated with explantation. And the type of infection, whether superficial or deep, and what determined the superficial versus deep. Superficial was simply redness in the absence of periprosthetic fluid, and the deep-seated infection included periprosthetic fluid. So those who had fluid collections were more likely to end up having their tissue expanders explanted. Additionally, looking at these things, infection with Pseudomonas species was associated in a significant way with explantation of the tissue expanders. So just to kind of recap that whole thing, the likelihood of salvage increased with the absence of any significant periprosthetic fluid, when there was no microbial growth from the fluid aspirate, when there was infection with staphylococcal species, when patients only required empiric therapy and not specifically targeted therapy for an identifiable organism, when there were the absence of systemic symptoms at presentation and a later onset of infection from the time of tissue expander placement. Likelihood of salvage was decreased with significant periprosthetic fluid, positive Pseudomonas aeruginosa culture, and that was a 0% salvage rate. Any identification of a specific organism requiring specific therapy, additional courses of antibiotics. So if after 2 weeks the patient persisted on empiric therapy, but there were still no culture results, they would be given a second course of treatment, and that was associated with the decreased salvage rate. Again, presence of systemic symptoms and earlier onset of infection following surgical placement. And so looking at the outcomes after treatment, for those who were salvaged, of these 19 patients, 95% rather, went on to definitive implant-based reconstruction. For the explanted tissue expanders, 4% had a second TE placed and subsequently underwent successful implant-based reconstruction. 28%, or 2 patients, had flap reconstruction, and 1 patient opted not to continue with reconstruction at all. Overall, time to completion of reconstruction was not statistically significant between the 2 groups. If you look for the range, it sort of looks like the salvage TEs were shorter, but it did not reach statistical significance for us. So again, comparing it to our previous data, prior to this initiative, we had a 50% salvage rate and a 50% explantation rate. With this, it improved to 73% on the salvage rate and 27% on explantation, or decreased to 27% of explantation. And so it compares favorably to other salvage rates in the literature that we've found were 25 to 64%. Looking at cost estimates for this, traditional management that in these we just looked at a 5-day hospital stay and outpatient follow-up was anywhere between $18,500 and $28,500. For this, going through our billing department, with the outpatient imaging and outpatient antimicrobials, it seems like the cost would have been $3,500 for oral antibiotics versus $11,500 for intravenous antibiotics. So there was a significant cost savings estimated with this management algorithm versus the traditional. So takeaways, again, ADM more common among explanted TEs, but not statistically significantly so. Their earlier infection was associated with decreased rates of salvage. Presence of systemic symptoms also associated with decreased rates of salvage. Gross purulence or Pseudomonas aeruginosa decreases your salvage rate, and prolonged need for antibiotics does the same. So early aggressive management of surgical site infection with TE, if you utilize a multidisciplinary approach, can improve salvage rates, it can decrease the overall cost, and hopefully improve patient outcomes. Thank you for your attention.
My presentation is going to focus on incisional management. These are my disclosures. I think it's no secret, and everybody realizes now, that perioperative optimization can reduce the incidence of surgical site infections and improve outcomes. And there are a number of things that we can do preoperatively, in the immediate perioperative period, and postoperatively, and you can see everything listed here. But the things that I wanted to really focus on in the immediate perioperative were the closure techniques, and in the postoperative, the incisional dressings, because that's really what this is going to focus on. Now, it's interesting, when you look at consensus guidelines for prevention of surgical site infections, they really don't address incisional dressings. In fact, what they recommend is that you just cover the incision with sterile gauze for 24 to 48 hours. That's all that's recommended. They obviously then go on to say using aseptic techniques is beneficial, but there is really no advocacy for any topical antibiotics. And many of us will use some sort of topical antibiotic, whether it's Xeroform or any of these other type of dressings, because they have antibacterial properties to them. We saw this in the last module, options for incisional management, and it ranges anywhere from sterile gauze to incisional negative pressure devices. And there are a variety of incisional negative pressure devices on the market now, some of which you'll be able to see out in the exhibit area. But some of the other things are Xeroform for low risk, hydrogels for minimal to moderate exudate, the hydrocolloids, alginates, and the composites, which is really what we're going to focus on with this presentation. So I wanted to go over some of the background behind Aqua and the clinical evidence supporting it. So it's going to be more of an evidence-based presentation, not so much clinical experience. But basically, silver is the definitive property of the Aqua, and it basically has a broad spectrum of activity. It inactivates enzymes and it binds with DNA. All of these tend to kill some of the microorganisms, viruses, and other fungi. So it does have a broad spectrum, and it is effective against some of these more resistant organisms. It has bactericidal and bacteriostatic properties, and it's not toxic to human cells. Resistance can occur, as we heard earlier in the prior presentation. However, resistance is rare. It's not common, but it will disrupt some of these electrolyte balances and interact with other protein synthesis activities. So basically, if you have a situation where a wound infection is evolving, we all know about the endotoxins that evolve, and this leads to decreased collagen production and impaired wound healing. And also with wound infections, the metalloproteinases are going to be associated with some of these delayed healing episodes and also cause some of the inflammation. Basically, what the silver does is it will sequester some of these endotoxins and then promote improved healing. And it's really shown to decrease the amount of inflammation and improve our overall outcomes and decrease surgical site infections. This is basically what the Hydra Fiber looks like. I don't know if anybody in the room has used it, but it's actually quite interesting. It's a carboxymethylcellulose material, and it's activated by moisture. So when you place it over a fresh incision, some of the fluid that exudes from the incision will cause that Hydra Fiber to turn into a gel. Now, within that gel is the silver ion, so it's 1.2% silver. And it's slowly released for about 2 weeks, but it has antimicrobial activity for about a week. So the recommendation is to actually leave this material on for a week. And it's worked really well in cases of tissue expanders, breast reductions, and things like that that I've performed. Now, there are a number of studies looking at this material, and most of them are in the orthopedic literature. However, some of them were, early studies were in burn patients. And if you look at these studies that were published between 2006 and 2009, they were all randomized control studies, and they were mostly for burns, donor sites, acute wounds, or diabetic foot ulcers. And they had comparisons to other dressings as well. And the main outcome wasn't that there was so much of a difference in wound healing, but that there was less pain associated with these dressings compared to some of the others. Now, the more modern clinical trials, and these have all been published between 2014 and 2017, again, look primarily at orthopedics. So orthopedics is in a unique situation because they're doing a lot of prosthetic reconstruction or prosthetic devices for joints and hips, so infection can be devastating because it could mean a loss of that hardware. But these are studies that have a reasonable number of patients, anywhere from 260 patients all the way up to almost 1,800 patients. One of them was a randomized controlled study. The other 3 were retrospective studies. And they basically had comparisons to sterile gauze, Xeroform, and Primapore, which is another form of dressing. Now, in these cases, the incidence of surgical site infections was significantly reduced using this Aqua cell, so 0.41% versus 1.71%. Very low incidence of surgical site infections, but because there's such a large number of patients, they were able to demonstrate significance. In the paper that just came out this year that was published in the Journal of Arthroplasty, and you can see these references on the bottom, almost 1,200 patients, comparisons with Xeroform, and again, the incidence of surgical site infection was 0.33 versus 1.58, and again, this was statistically significant. There was a study that was done in the Netherlands where there's a lot of randomized control studies done, and I actually met Dr. Clem and discussed this paper with him. But basically, he used this Aqua cell in breast patients, not all necessarily prosthetic reconstruction patients, but this was a true randomized controlled study. So basically, they used the sealed envelope company to decide what arm these patients were going to go into. 219 patients, there were 99 in the Aqua cell group and 120 in the control group. And the primary outcome was strictly surgical site infections, and secondarily, they looked at patient satisfaction. These are some of the demographics comparing the 2 cohorts of patients, and if you look at median age, body mass index, diabetes, tobacco, anesthesia scores, and clinical stage, there was no significant difference between any of these categories. If you look at the operative characteristics, whether they had a lumpectomy alone, sentinel node, axillary node dissection, mastectomy alone, duration of operation, drain use, and duration of drains, again, there were no significant differences between the 2 cohorts. So they really wanted to make sure that these were going to be comparing apples to apples. If you look at the results, it was interesting. The total incidence of surgical site infection in the Aqua cell group was about 8% compared to 12.5%. Now, this was not statistically significant, but it approached significance. The incidence of superficial infections was slightly less at 6.3 to 9.7, again, not statistically significant, and deep infections slightly less, but again, not statistically significant. What was statistically significant was the number of symptoms that patients presented with. So in the Aquacell group, there were more than 2 or more symptoms in 10% of patients, but it was in 22% of the control group. And if you look at patient satisfaction, it was about the same between the two, with Aquacell having slightly higher readmission rates, reoperation rates, and antibiotic use were not statistically different. This is just a patient who had Aquacell dressings, just so you can kind of see what it looks like. It's the basically duoderm skin adhesive, the Hydra Fiber with the silver ion that's slowly released. It basically keeps the dressing moist. When you peel it off after about a week, it's got a gel sort of consistency, and the incisions actually look very pristine with minimal inflammatory changes. So in conclusion, I think that we've heard from all these presentations that infection remains a persistent problem, but I think that there are considerations to be made to optimize incisional dressings. Consensus guidelines don't really identify this as an area of concern, but I think clearly there is benefit to what we put on these incisional dressings. Aquacell has demonstrated benefit, but I think we need more randomized trials, especially in the breast world and in the plastic surgery world. We've got plenty in the orthopedic literature, but we just need to broaden and extend this out into the plastic world. Thank you very much.
So we have a couple of minutes for questions. So while waiting for people to come up, I'll ask. First, Mo, I noticed in the case that you presented that it looked like you had steri strips underneath, and then you put this on top.
Right. So initially, I was wondering if steri strips were going to be a detriment, but actually, in speaking with the company, steri strips are fine, because you'll still get some of the exudate coming, or the moisture coming out into the gauze, and then you'll still get the benefits of that Hydra Fiber and the silver ion despite the steri strips. So the steri strips are penetrable to these moisture materials in the ion.
And then one more question, then we'll get to Mike. You know, you guys have talked recently a lot about red breast syndrome, and you know, this comes up in a lot of the studies. And how's this? Are people counting red breasts as infections, or you know? How would you recommend we deal with that?
That brings up a whole nother topic of discussion. So red breast syndrome is actually complicated. And the thought behind it historically was that it was a kind of an inflammatory reaction. But I think really if you get down into the nitty-gritty, I think there probably is a subclinical infection that's probably associated with red breast syndrome. And it may be because of the dermal lymphatics that are disrupted. Now, whether a dressing like this will improve outcomes or change outcomes in the setting of red breast syndrome, I'm not really sure how that's going to play out, but it's certainly something worth investigating.
Great. Mike.
Yeah, hey, how you doing? I have two questions. One first for Dr. Orgel. You noticed that you were saying inflammation is the thing in obesity. And as you know, I mean, free radicals has been my thing for 30 years, and
Yes.
looking at ways of reducing oxidant stress. The question I have is that basically there are ways to test for systemic oxidant stress. I mean, I've done it on myself, and I think actually it's a reasonable thing to do. I'm not aware of any big studies, but are there any thoughts of doing preoperative ways and then also trying to treat it? Because related, like the previous thing was a neuro thing where carpal tunnel syndrome, we showed that oxidant stress contributes to that. So I think there are things where the use of systemic antioxidants would be of use and ways of checking that. Are you aware of anyone looking into that?
I'm not aware. We have a big audience here. If anyone aware of anyone using antioxidants in obese patients as a preventative measure. So anyway, it's a great topic to study.
Okay, thank you. And also I have a question for Mo. Concerning this dressing, the question I have for you is, on one hand, you're mentioning this particular dressing because of its anti-infective ability tends to be left on for 7 days. So when you do that, it does two things. You're leaving it on, and then the wound can actually start oozing, and you start getting a milieu there, so that could be a negative aspect. On the other hand, in these double-blind studies where you place it on a regular incision, you're keeping the dressing on longer than you ordinarily would have it, so you could be actually affecting that. And the question is there any thought to, like what we used to do for certain things is you have the dressing on for a little bit, where you have the maximum ooze, remove it, change it, and put some other stuff back on, and see if that would have a better effect.
Yeah, I would imagine that you probably could. I think some of the benefit of this is that you're leaving the incision undisturbed, so you're maintaining a semi-sterile environment. I mean, there's obviously bacteria that's caught into the gauze, and if you do have tremendous amounts of exudate, then it probably makes sense to take the dressing off a little bit earlier. But if there's nothing that's really showing up on the back side of it that you can see, then I would recommend just leaving it on for those 7 days.
Now the other question is related to the development of this product. Has anyone done any culturing underneath over time where this thing is sitting here as being moist and seeing if you can actually find some organisms and correlating that with outcome?
You know, I haven't seen any of those studies. I would imagine that the company might have some data on that, but I'm just not aware of any of those culture studies.
Okay, thank you.
Can I make a comment also related to that question? What I've noticed is that dressing, the hydrocolloid dressing, almost acts like a wick. It seems to absorb any fluid. So when you take the dressing off, the wound area seems very dry, and that's because the dressing has really absorbed all the fluid away. And I think that keeping that area free of a bunch of moisture probably keeps it from having a bunch of bacteria growing.
All right, for Dr. Vila, you mentioned you send all these people to an ID clinic. You seem to have immediate access. For those of us who are mere mortals and live in hospitals where we don't have that, how is there something we could do short of sending somebody to an ID clinic in terms of ordering ultrasound and specific antibiotics you'd recommend?
I'm sorry, what's the specific question?
What do you do if you're in an institution where you don't have immediate availability of an ID clinic?
So, I mean, I think if you can, and we can start this also, but it's usually the minocycline and rifampin are the drugs that it gives. You can just start those and get an ultrasound. I'm not sure. This protocol has really greased the wheels for us in terms of being able to get these things done. So, probably the ultrasound, it may not be as critical, but at least start the antibiotics and be aggressive with it up front that way.
Of your patients that you got ultrasounds, what percentage of them needed an aspiration?
That's a good question. I actually don't know the answer to it.
Because in a place like yours where you're doing hundreds of these all the time in some of the high volume centers, I think that's possible to do. But for a lot of people out here, they're probably in lower volume centers, and it may be harder to get that protocol arranged.
Right. I absolutely. Things are not usually this easy for us, but luckily the infectious disease department has a lot of PA support, so you can usually find somebody who can see somebody right away, essentially.
Very good.
Can I make a comment
Yes.
also? I have a different setting, but just to comment, I'm in a private practice setting, and so we don't have the facilities that you do necessarily or the resources, but we do have a relationship with the infectious disease group or a couple of infectious disease doctors, and so they have actually put together a protocol. So having that relationship with an infectious disease doctor, I think, is helpful. And we've really had no problem trying to get ultrasounds arranged, but it's probably not within the first day or two, but we probably get them within 3 days, I would say, and I would say probably less than 10% of those patients get a fluid collection that needs to be aspirated.
And in some ways, if it's something that you can establish, I know that there's a little bit more flexibility. People are a little more responsive in the private practice world than they actually are in the academic world. So it may be something that would be worthwhile investigating to at least establish a relationship with a practice, because I think we have a system set up, but there is probably a component of generalizability that you could have if you take the time to establish the relationships up front.
Mo, what do you do?
Typically, we'll get, somebody comes in with redness. I mean, we're going to start them on antibiotics. It depends on how severe it is, but it could be oral, it could be IV. We're always going to get an ultrasound, usually going to get an infectious disease consultation. And in terms of like aspiration, it's not something that we typically do. If there's fluid with cellulitis, I'm typically taking those patients back to the operating room.
And I'll just say anecdotally, for me, I agree with you. I've not really had a significant infectious complication that was not preceded by a fluid collection. So I was surprised a little bit by our data where it was people who had drains in were the ones who were more likely to have explantable infections, whether that was a conduit for the infection. But again, normally I've found fluid collections predispose rather than the drains.
So one question that comes up is how do you manage drains? And if we polled the audience, there's going to be a great variability. Let's just hear from the three panelists. What are your feelings on the drains? When do you take them out?
So usually I do fewer than 25 cc's a day for 2 days in a row and an absolute maximum of 4 weeks, with antibiotics being administered the whole time.
And do you have any data to support the antibiotic usage?
Nope.
Okay.
So
It makes me feel good.
I go to Antibiotics Anonymous a couple times a week. Yeah.
On these prosthetic cases, I typically use 1 or 2 drains. More often than not, I'm just using one. I use a biopatch on every drain. And I keep patients on antibiotics till the first clinic visit. If everything looks good, I stop the antibiotics. So that's somewhere between day 4, 5, 6. I used to keep antibiotics until the drains came out. I stopped doing that. So I've compromised a little bit on these skip protocol measures. I still give them at least 2 days because there is some retrospective data to support keeping patients on antibiotics for 2 days, even though the randomized control study that was done out of Duke earlier this year demonstrated no benefit to prolonged oral antibiotic therapy. But I still keep them on the antibiotics for at least a couple of days.
Dr. Newman?
Sure, yeah, to answer the drain question, I do something similar to Dr. Villa, 30 cc's or less for 2 days in a row and try and get the drain out within 2 to 3 weeks, but then have a maximum of around 4 to 5 weeks. Regarding antibiotics, I do keep them on antibiotics for the whole time that the drains are in. When I first started practice, I really was, about 10 years ago, I really wanted to follow all the rules and limit the antibiotic exposure. And so I did just do that kind of perioperative 24 hours of antibiotics. And I did notice a lot of infections, and whether that was just because I was early in practice or not, but that got me scared enough that I changed my habits to doing antibiotics for that entire time that the drains are in, only for prosthetic cases.
The interesting thing is when you look at all the retrospective data, it always shows the benefit of prolonged antibiotic therapy. But when you look at the randomized control studies, then they don't show any benefit to prolonged antibiotic therapy. So it's a little perplexing, and it kind of makes you wonder about the limitations of retrospective studies sometimes in this regard.
Right, and it shows you how we have 3 smart people up here that the literature is pretty clear, and we're making decisions that are contrary to what the literature says. So
I noticed you didn't answer that question. Maybe you can tell us what you do with the antibiotics and drains.
Oh, yeah, well, we never have complications in our hospital, so, I do the usually just 1 preoperative dose, except for when I have a prosthesis in, and then I'll give them a few days. But I don't leave them, I do like what Mo does. But I'll be the 4th one to go against what the literature says, but we need a better study out there, I think. And you need multiple randomized prospective studies, because I think each of us have probably run into a situation where we've had an infection where a patient, for one reason or another, wasn't on antibiotics, and then based on your last complication, you make that decision rather than, I guess if we were stronger people and had better spines, none of us would do it. But we have 4 for 4 that go against the literature, so that's a little disturbing, I guess. But all right, well, thanks very much, and appreciate everybody coming to the symposium.